Okay, well, welcome back, everybody. After the talks this morning, we're going to move in a policy direction next. And we're going to hear about the National Institute for Health and Care Excellence, their approach to real-world evidence and evaluations using observational data. After that, there will be a panel discussion. So for those either online or here, please do prepare your comments, your thoughts about what you've heard from all the speakers, your suggestions for collaborative opportunities and further questions that you might have. So to start us off, we're delighted that Stephen Duffield from NICE, the National Institute for Health and Care Excellence, has been able to join us. Stephen's role involves the continuing development of NICE's real-world evidence framework, collaboration on demonstration projects, and helping to transform NICE's use of real-world data across guidance products. He's involved in upskilling individuals within the institution and externally, contributing training and technical forums. He has a degree in medicine and a PhD in public health, and previously worked as a clinical doctor and a guideline developer for NICE. Stephen, we're really looking forward to your talk.
Thank you very much, Jonathan. So hopefully you can all hear me. Do I have to click? So I've got my clicker here. Perfect. But where am I pointing it? It's just, did it work? Use the keyboard if it's easier. Same effect? Yeah, I'll just do that. I can use the keyboard. Cool, so it's really great to be here. Fabulous to be among such really great speakers. So really grateful for the opportunity and glad to have made some new relationships already. So I'll be talking about basically how NICE uses real-world evidence, which by extension is essentially how we could make greater and better use of secure data environments. So the first thing to say is, what is the National Institute of Health and Care Excellence? I'm being made a bit louder. Okay, that's good. So slightly different definition, I suppose, than the one that Jonathan gave earlier, but NICE's core purpose is to help practitioners and commissioners get the best possible care to patients fast, while ensuring value for the taxpayer. So really we hold in tension those two perspectives, the perspective of the individual and of society. But NICE, it's a HTA body, by the way, in case you didn't know, so that's a health technology assessment body. We also have this dual function, so we also provide clinical practice guidelines, and those are guidelines which cover the entire patient journey. And so NICE is kind of in a reflective mood recently. It's been realizing that since the pandemic, the health and care system has been changing. We're seeing massive health service pressures in the NHS, huge wait lists, and we've also got some good problems. We've seen a huge growth in innovation of new technologies and medicines coming through. And of course, what we've been discussing today, data. There is more data than ever. Access to data is improving all the time, and the quality of that data and our understanding of it is improving. So NICE went out to its stakeholders to ask the question, how does NICE need to change and adapt the way it works in order to stay relevant in this changing system? And so one of the key kind of aspects of feedback that we got was quite reassuring, as we need to stay true to our core values of transparency in our decision-making, rigor in our assessment of evidence, and independence of our decision-making committees. However, there were some ways that we now need to change and respond to the new world that we're stepping into. So NICE needs to produce guidance which is more relevant. So data kind of ties into this. We can use data to help us map out variation across the UK, to help us understand where guidance is desperately needed. We can use data to define unmet need and where NICE needs to focus its efforts. More timely and usable. So Richa mentioned in her talk living guidelines. So we need guidelines which have modular updates. It's no longer good in the new world for there to be a landmark trial published and then NICE guidance updates 5 years later. I think we can do better than that. We can respond faster to data. Greater demonstrable impact. So we'll be talking a bit about how NICE uses real data. but we'll also, what NICE is doing, which is new, is it wants to track its own impact in the system. So once a piece of guidance is published, we can then follow the actual uptake of that guidance, and we can look at subgroups, subpopulations, and see how is it that uptake varies across those subgroups. Is there something else that we need to change about our guidance? And that way we've got a kind of massive audit cycle going on. So I'm not going to dwell on these slides too much because I think my co-speakers kind of covered it better than I'm going to. But essentially, I just find this graphic quite useful at the low resolution. So you have your kind of national registries. These figures are made up, but they're kind of exemplary, which cover almost all the patients or all of the patients in the UK. However, they don't contain all of the features that we want to be able to answer all of the kind of interesting questions that we have, particularly around causal inference, where you need really good information, for example, on covariates. And then you have your more kind of clinical research focusing, so your registries. So here we could have perhaps 100% of features, but the coverage is not good. And so you can draw from the relative strengths of these two kinds of data sets. And then you have where the rest of the data is, which is in the routine clinical notes, which is not joined up and has huge amounts of missingness. Perhaps there's also elements in the future that we might be able to tap increasingly into unstructured data using NLP methods to really bring down that level of missingness. I think a better paper to discuss this is Jess Morley and Zhang's paper, where they provide the higher resolution view, which shows a real web of different data creators in the NHS, flowing into our data curating organizations. And then at the top there in green, you can see all of the data consumers that exist in the NHS. Do check out that reference at the bottom there. So the HCR UK, they are an organization within the UK, and they're trying to make this web of data resources more searchable. So as we've been discussing, the picture is going to change slightly. So we're looking to see the existence of some national SDEs, and then in the bottom circles there, if you can just about see it, some subnational SDEs. And again, we can draw from the relative strengths of these two different types of SDEs. So subnational SDEs are more flexible, contain richer data, but obviously the national data has better coverage. Again, won't dwell on this, Rachel covered it, but essentially these are the two key policy documents. The first known colloquially as the Goldacre Review, and then there's Data Saves Lives, which has a bit more focus on policy. But the key takeaway is that the Department of Health and Social Care in the UK has made a clear statement that NHS data is going to, in all cases, be accessible through secure data environments. And if it's not accessible through secure data environments, this will be with severe restrictions. So then there's common data models as well. So the secure data, the SDE network has agreed that it's going to adopt this OMOP, common data model. So this is going to bring more consistency to our data resources. And then adoption of the common data model has many benefits. So we've been talking about reproducible analytical pipelines, reducing the burden for researchers in terms of informational governance, and there's also benefits in terms of standardized de-identification processes as well. Crucially, from the NICE perspective, I think we're quite interested in this idea of common data models, because this will start to align us increasingly with networks here in the US, which are adopting OMOP models, and then also in the European health data space. Our ability to link UK data across these international data sets will boost the power to answer questions, particularly in areas where the populations are small, so subgroups and rare diseases. So that's the data situation which we've spoken a lot about. How does NICE actually use real-world evidence which is derived from real-world data? I'm going to focus on the examples which are kind of more about the structured data that you'd find in SDEs. So NICE commonly uses data to characterize disease, care delivery, and outcomes. We use real-world evidence, of course, to look at diagnostic tools, diagnostic tests, and there's also the idea, if you look at some of the work that our regulators are doing in the UK, that we can use our secure data environments potentially to actually train data-driven algorithms to actually help relieve some of the burden on the front line as well. We use real-world data commonly to generalize our randomized control trial data, so we can use descriptive information to examine differences in patient characteristics and outcomes. And then there's your causal inference questions, which is what we've been discussing a lot today. And all this information and more heads into our economic models, which is what we use to define the cost effectiveness of treatments. So this is a review that was done by IQVIA, but what it shows is that over the decade, I mean, going up to 2021, but since 2011, the increasing inclusion of real-world evidence in NICE guidance has been quite astonishing. So some key milestones include the establishment of the Cancer Drugs Fund, which began in 2011, then the linking of the Cancer Drugs Fund to the need to collect routine evidence, which occurred from 2016, and then the Innovative Medicines Fund as of 2021, which will expand this out to non-cancer topics.
Do you want to just explain NICE STA?
Of course, yeah. So NICE STA, so that's single technology appraisal. So this review looked at basically technology appraisals, which looked at individual medicines and health tech. Okay, so we've established that real-world evidence is used increasingly to drive policy in NICE. However, the evidence dossiers which are submitted to NICE can be hundreds of pages long. So how can we estimate the actual influence of these kinds of evidence and this kinds of data? So this is a review which was done looking at cancer appraisals, and they were interested in the use of real-world data to parameterize or inform our health economic models. And they found that 96% of company-submitted cost-effectiveness analyses included real-world data, real-world evidence in some form. And in the majority of cases, NICE committees are very accepting of this kind of evidence. They like it. It helps, particularly the descriptive use cases are highly informative. So this would be utilities, which would be about defining the burden associated with different health states, defining costs and resource use associated with treatment, which are key drivers of long-term cost effectiveness estimates, and then patient characteristics and treatment outcomes, or the key uses in economic models. This is some unpublished work that we've done on our team recently. We were also looking at other ways in which you could measure the influence of real-world data, real-world evidence in NICE processes. And we were interested in where is it that NICE committees actually end up discussing real-world evidence. So you may or may not know, so on the NICE website, we have transparent as possible, laid out all of the committee discussions with regard to the different kinds of evidence and how they deliberated it and then how they came to their conclusions. So we were looking at how often they actually talk about real-world evidence. And what we found was slightly surprising. We weren't expecting to see so much discussion of real-world evidence for answering causal questions, comparative treatment effects questions. So we found that actually occurred in over 25% of cases. So you could ask the question, well, was it influential? Was it supplementary to randomized control trial evidence? So we also asked the question of whether this was, how often was real evidence the pivotal or the main evidence? And this occurred in about 9% of cases. So some key examples that you'll find, for example, in medicines appraisals will be where you have a rare disease scenario. The company is not able to recruit enough patients or for ethical reasons can't have a control group. And so you have a single arm trial and that trial has to be contextualized. And that will often be contextualized against a real world data cohort. So we've been talking about how real world evidence supports decision making at NICE, but NICE can also change the way that it works to help support to help make the most of real world data. And so this is one of the ways that NICE is changing the way it works recently. This was the renal cell carcinoma pathways pilot. You can find the discussion of it online, again, on the NICE website. I have to explain a little bit of context. So what would normally happen is a company would come with their evidence dossier and they would present an economic model. And this economic model would focus on the very specific treatment indication or decision space. So it would be limited in that way. And then you have multiple companies coming, perhaps with their own economic models, and there'd be small differences between those models and the assumptions that they've made. And so you have this inconsistency across appraisals. And so what we were trying to figure out was whether we could do a whole pathway model. So in this scenario, you'd have all of the treatments mapped out for renal cell carcinoma, an economic model which encompasses the whole thing, and then perhaps a company in the future would come along with a new randomized control trial, relative effect, and this would be inputted into a model which is appraised consistently across technology appraisals. And so this is a Sankey diagram, which you can see up here, and I think that really demonstrates the complexity of treatment in the real world. And so starting at the very top, you have the first line treatment, and then the patients kind of flow into the next level, which could be the second line treatment. In purple, you can see some patients flow to death, some patients flow to cure, no progression, and then it goes down to second line and fourth line. And I think what this shows is that the benefit of real data to show us reality in all of its complexity compared to the huge assumptions that we have to make on models which are based only on randomized control trial data. This was another quite interesting finding, I think, from that same pilot. So in this case, we've got survival outcomes. You've got a key trial there. So the treatment arm is the dark black line at the top. And then you've got the dotted line in the middle, which represents the standard of care group, sunitinib. And then you've got the real world arms, which are kind of multicolored and split by a different year. But what you can see is that the standard care arm in the trial significantly outperforms the same treatment given in routine care. And so this presents a bit of a problem for NICE, which I think we're still kind of grappling with. But basically, if you input the trial standard care arm, you will almost double the expected life years gained from that treatment. So can we use real data to give us a more realistic estimate of what outcomes are likely to be in reality so that we value drugs appropriately? So this is my last slide. I'm just going to say we have this framework, the NICE's real-world evidence framework. It mentions other frameworks such as the target trial approach, but this document has kind of dual functions. So firstly, it describes where and how real-world evidence can be used to drive decision-making at NICE. And it also has this best practice principles for the design and analysis of real-world data. So the key thing about this methods document is that it is being updated. We're keeping it living. So we've already had 2 rounds of updates. This include adding things like the protocol, the real-world evidence protocol tool, the Harper tool, more advice around systematic searching for fit-for-purpose real-world data. Our most recent update was around transportability methods. But really, we're looking to you guys, we're looking to the academic world to really help us with these methods documents. Give us the signals of best practice that we should be including in them and that we should be using for our critical appraisal processes. And this will help improve the evidence that comes to NICE and therefore the decisions that we're able to make. So, thank you very much for your time and attention.